Go ahead and get the recording started. Welcome to the last chapter of trauma. We are almost done. You guys, I don't know if you've noticed, we have 3 classes left after this for the last module, and then we are done until the boot camp. So in the next week, that's it. There's no more lectures. And then you guys get obviously the holidays off. Happy holidays, by the way, and a little bit of January before we get to the hands-on. Um, if you have any questions, if you're a little bit behind or whatever, that's fine. Let me know. We'll work through everything. If you haven't quite paid up your tuitions and everything, we are 3 classes away from being done with the lectures. So gotta get on that because again, I can't let you graduate until you've finished that portion as well. Um, but anyway, I'm not a bill collector. I'm not a debt collector. I'm not going to harp on that. Just remember that that is part of the stipulation for the in-house program. Um, Tonight we're going to go over orthopedic injuries. This is a fairly long chapter. However, it's also a very hands-on chapter. So we're probably going to not really sugarcoat, but we're going to kind of speed through a couple of different sections of this because a lot of it just may not make any sense in this kind of a format. We're going to really do a lot of this stuff that's in this chapter when we get to the boot camps where you're hands-on, you're able to see what the deformity looks like. Actually, put on the triangle bandage, put on the splint, and all of that stuff, and it actually makes sense. Otherwise, I mean, what good is it? I can tell you what a splint is, and we're going to go over that tonight. But actually, trying to step you through how to put it on, I'm not going to waste your time or mine here in this particular platform. That's definitely a hands-on thing. So you will see that at the boot camp. If you have any questions about something about, either a cognitive aspect of it, like when we talk about pulse checks and um, things of that sort, or procedural things, then absolutely we can go over that. I just don't want you to worry about, like, if we get to the end of this chapter and we haven't talked about how to actually put on a triangle bandage, that's okay. That's not what we're going to be doing tonight, even if the slides try to hit it, because these slides are meant for a traditional classroom. They're not really meant for doing it the way that we do it. So some things we will skip over. All right. So like I said, tonight's going to be the kind of trauma that we deal with when you think about people in wrecks, right? We've talked about different things, different injuries to different regions of the body and what that does, but this is going to be the typical trauma. The, oh my God, I broke my leg or I broke my arm. That's what we're focusing on tonight. The human body is a well-designed system. Your bones do a couple of things, right? So they give you the form to stand up and move. They also protect certain organs. We're not so much concerned about the organs tonight. Now we're actually worried about the bones. The bones and muscles are susceptible to external forces that can cause injury, like it says. But the thing, I mean, yes, some of our skeletal system is designed to take an impact, but it's only designed to take so much. An example of that being that the back of your skull is thicker than the front of your skull, because usually if you're going to get a bad injury, it's you're hitting the back of the head. If you were to fall down, fall backwards, the back of the head hits the ground. Over years of that, our bones have thickened up back there. Usually your front doesn't get hit as hard because you tend to see that impact coming. So you would move your head or whatever. You have other defense mechanisms for that. But we're not just worried about the bones. We're also worried about the muscles, the tendons and cartilage, and the ligaments that are also at risk whenever we have injury. And keep in mind that your tendons, cartilage, and ligaments, they're not very vascular. And because of that, they take a long time to heal, right? That lack of blood flow that's there, even when everything's in check. If you have any kind of bleeding involved, now you got even less blood flow going to that area. But because there's less blood flow in general, these injuries don't heal fast. Usually, what might be like if it was a muscle injury or something of that sort, you might be back up and running in a couple of weeks. Ligament injuries, tendinitis, tendons in general, those injuries sometimes will take upwards of a month or more, depending on where the injury is at. Musculoskeletal injuries are among the most common. Um, Not everything is a break. Some things are mistaken to be breaks. what they don't know. And truth be told, neither do we. We don't walk around with an X-ray machine. So we do the best we can to kind of narrow it down, figure out what happened. We rely heavily on our mechanism of injuries for these when you're doing your assessment. And um, usually, if we feel like it's something that's not that necessary that they take the ambulance, we may encourage them to find an alternate route or whatever. But remember, if it is an emergency, if they do need the ambulance to get them to the hospital, get them in the ambulance if you can and get them to the hospital. Not all injuries require that. If they broke a finger, do you really need to be the one to carry them? Not necessarily, but they may want to still get checked. So there's a line there. You can tell your patients, your injury definitely warrants a trip to the ER, but if you're worried about the cost, you don't have to ride with us. If it's an injury to their spine, their neck, a femur, their hips, something of that sort, then yeah, because usually they have to be laying down. That's the only way to really safely get them from point A to point B. And in those cases, an ambulance ride is the way to go. But in the real world, somebody with a broken ankle doesn't necessarily need you to be the one to bring them to the hospital. So just keep that in mind. Don't focus solely on the musculoskeletal injury without first determining that no life-threatening injuries exist. So that's still the case, right? We're talking about kind of the easier stuff here as far as life threats. Um, but you may get some people who are really mangled up, like all their limbs are pointing in directions they're not supposed to point at. They've got bends where there shouldn't be bends, and these kind of things. Just don't get tunnel vision and forget that they may be unconscious and lost their airway as well. Your muscular system includes three different types of muscle. We have already talked about all of these in the past, but we're going to do a quick review. You have your skeletal muscle, smooth muscle, and cardiac muscle. Skeletal muscle is when you think of muscle, that's your skeletal muscle. So your biceps, triceps, quads, hamstrings, all the muscles that allow you to move are your skeletal muscle. Um, Named that because they actually manipulate the skeleton. Your smooth muscle is your intestines, your stomach, your bladder, your blood vessels. Those are going to be smooth muscle. We don't have control of those. They kind of do their own thing. They're still at the direction of the brain, but we can't say, I'm going to slow my digestive tract down. It just doesn't work like that. And then your cardiac muscle, which should only be found in the heart. Um, if it's found anywhere else, that's usually, cancer or something of that sort. But your cardiac muscle it's electrically conductive. They are capable of creating their own shock when they need to, and they serve that purpose to make sure that the heart still beats. All right, so we already talked about that. This is your skeletal muscle. This is your smooth muscle. You don't really have to go this deep into it unless you want to take like an actual anatomy class. And then your cardiac muscle. All right, for your skeleton, skeleton gives you your recognizable human form, and it also protects your vital organs. This makes up, well, actually, let me rephrase that. There's 206 bones in the body. Does anybody, how many bones does a male have? Okay. Why is that? We're being recorded, just so you know.
That you
All
let
right.
me?
So yeah, and that's why I was asking. So depending on your religious views, you're taught that actually you were taught that man lost a rib for uh, for a woman to be made. However, still 206 bones. Actually, there is no one extra rib or one less rib, not by science. So if you looked at a cadaver and you counted the bones, it's 206 bones for a male, 206 bones for a female. It's all the same. But yeah, I mean, like I said, we all, well, I say all of us, but those of us that grew up in church, we were taught that story. And I think, now granted, I got this from a private school in Jasper County, but they actually taught us in science, in fourth grade science, that man had one less rib than a woman, which actually isn't true, but that was part of the curriculum because of the books they used. So here's your skeleton. Like I said, 206 bones. Um, your bones serve a couple purposes. Not only is it for protection and movement, but they also make your blood cells, your red blood cells. So the bone marrow on the inside of the bones makes your blood cells. They also store blood. The amount of blood that's inside of your hips, if you were to lose it, that would be enough for you to die from internal bleeding. That's one of the reasons why elderly falls are so critical, is because they're much more at risk for breaking a bone or fracturing things. And if they fall and break their hip, they could bleed out. The bone break itself is nowhere near, that's not really our priority. It's got its own set of issues and risks, but we're really more concerned about blood loss at that point. So your skull protects your brain. Um, Pretty straightforward there. Your thoracic cage, which is your rib cage, this protects your heart and lungs and the great vessels that are in that area. The pectoral shoulder consists of two scapulae and two clavicles, one on each side. Those muscles or those bones come together to form your rotator cuff, so that your arm can get kind of close to 360 degrees of movement. You are a little bit limited. It's not fully 360, but it's pretty close. If you ever tried to do a full 360, you would find like when you go back a ways, your arm kind of levels off for a bit. You don't make a full circle, but you can still wave your arm ultimately all the way around. So you've got pretty damn close to 360-degree movement. The big difference or the big things I want you to know here is remember what bones are what. So your humerus is your upper arm. Your clavicle is the collarbone that's on your anterior side, the front of your shoulder blade, or I'm sorry, the front of your shoulder. And then you have your scapula, which is the actual blade in the back. The scapula usually doesn't break. It's pretty hard to break that bone because it moves very weird. It doesn't actually rotate or pivot or anything. It slides. It'll slide around depending on whether you're moving your shoulders forward or up, that kind of thing. The clavicle is actually your most at-risk bone for breaking. So that's an important one to know. You're probably, if you ever get any questions on the registry about broken shoulder bones or anything, the clavicle is going to be the one that they're probably referring to. So make sure that you know that particular bone. All right, your upper extremity extends from the shoulder to the fingertips and is composed of your upper arm, which is your humerus. And then you have two bones in your lower extremity, like the distal ends of your extremities. You have your ulna and your radius. Remember, your radius is on your thumb side. That's why we call that the radial pulse when we check it. If you can just remember that, you check your radial pulse on the thumb side. It's called that because of that bone. If you guys have any patients that have a break to their forearm, be it one of these bones, it's usually safe to assume that they broke the other one as well. Um, those bones typically are broken in tandem. It's pretty rare that one breaks and not the other one. For your hand, we have three sets of bones. You have your wrist bones, which we call the carpals. So if you've ever heard of carpal tunnel syndrome, it's referring to the bones of the wrist. Then you have your metacarpals and your phalanges. Your phalanges are your fingers and toes. So even when we start looking at the feet, the toes are called phalanges. Your pelvis supports the body weight and it protects the structures within the pelvis. So your bladder, your rectum, damn near killed them, and your female reproductive organs, those are protected by your pelvis. Your pelvic girdle is actually three separate bones, but they're fused together. So, not to go way off into the weeds, I'm not going to make you guys know all the different portions of your hip, but the big thing that I want you to know is if you've heard of the iliac crest, that's referring to the top. So keep that. That's a good landmark because you may see that in a test. For your lower extremities, these are built just like your arms. So your femur connects into your hip. That's a ball and socket joint, just like your rotator cuff. It allows you to get pretty much 360-degree motion of your leg. Your femur is one solid bone. It's actually the biggest long bone in the body. It's also the hardest one to break, but it does happen. You have your patella, which is your kneecap, and then you have your tibia and your fibula. And if you look, it actually does a good job of showing that in this picture. Your tibia is your weight-bearing bone. That's the thick one that you see. So when you think about somebody's shin getting hit, it's their tibia that's getting hit. The fibula is feeble. It's not a weight-bearing bone. All that bone does is it allows you to pivot your foot, turning it either medial or laterally. All right, and then for your foot, just like your hand, you have three different parts. The only difference is instead of calling it carpals, they call it tarsals. So you have your tarsals at the ankle, your metatarsals that make up your actual foot, and then your phalanges, which are your toes. The bones of the skeleton provide a framework to which the muscles and tendons are attached. I'm not, if you guys have ever heard of origin and insertion, that's referring to where a muscle anchors itself versus the side that actually moves a bone. An example of that would be your bicep the origin of it is up at the anterior portion of your shoulder and at the top of your humerus. And it inserts into your forearm just below the elbow so that when that muscle contracts, it pulls your arm in. All of your muscles operate that way, and they can only operate in one direction. So if you damage your bicep, for example, you may not be able to curl your arm in, but your triceps still work, so you can straighten your arm out. Or if you, let's say, you completely rip your bicep off of your arm. This happens, you'll see some sports injuries where this has happened. People will do this with their chest, especially if you have a bunch of gyms in your area with people who like to lift a lot of heavy weights. Sometimes they'll have injuries where they've ripped a muscle off the bone. Um, all of your muscles they're under tension all the time as long as you are awake, or not even awake, but as long as you're alive. So if your bicep rips off the arm, your tricep no longer has anything to work against, and it's going to straighten your arm. It's gonna condense down without any resistance from the bicep on the other side. So it'll actually lock your arm out straight. You'll see where that can happen. Sometimes people will if they mess up their tricep, their bicep will pull their arm in. They won't be able to straighten their arm out. So just knowing how your muscles are working. If you see somebody that says that their arm is, or their leg or whatever is locked in a certain position and they can't seem to move it, it's probably because they physically ripped that muscle up that is the one that's supposed to do that move, or it could be a neurological issue where they just no longer can control that muscle. Sometimes if they get hit in the spine um, from an injury, that may be one of the things you see. They may still be able to feel, but they have no control. Or they may be able to make the movement, but they can't feel it. So that's why when we go down to their hands and feet, we're trying to check for that pulse, motor, and sensory. You want to make sure they have blood flow. You want to make sure that they can move it and feel. The movement and the perception of touch is two separate parts of the spine. So you're checking for both. Back on your anatomy and off of my tangents. A joint is formed wherever two bones come into contact and they're held together by ligaments. So tendons will anchor your muscle to bone, and ligaments will actually just hold bones together. So you've got ligaments all around your knee, you've got ligaments at your elbows, your shoulder, where your feet move. All of those movable joints have ligaments holding the bones together. And then depending on the kind of joint you've got, particularly the ones that move, they have synovial fluid within them, so that keeps them lubricated. And it's a big thing if you respond to a patient that has had, like, let's say they've had a knee injury or a sports injury in the past. Um, they may have issues where they're losing fluid. It hurts them to move their joints. They may not be able to move their joints because they kind of lock up. You may run into that. All of that has to be there. The ligaments, the synovial fluid, the tendons holding the muscles in place where they need to be. Everything needs to be there for the bones to move like they should. If any of that is missing, then you start to get compromised movement. All right. Injuries to bones and joints is often associated with injury to the surrounding soft tissue, known as the zone of injury. Usually, this is because a lot of the injuries that we take are because of direct blows. Something had to hit us. It's pretty rare that you will do damage to a bone by your own body weight. Not to say it doesn't happen. If you imagine running down a field at full speed and then trying to make a 90-degree turn without changing direction, if you don't plant your foot right, the weight of your body might twist your ankle. That's an exception to that, but most of the time, especially with what you're going to be called out for, a lot of the injuries are because something external hit the body. So direct blows is one of the first things that we're going to look at when we're looking at our mechanism of injury. Is what hit you, what caused this. You have indirect forces, twisting forces, which would be that running in the field I was talking about, and then high energy forces. A direct blow fractures a bone at the point of impact, and it's almost like hitting concrete. You know how when you drop something heavy and hard on concrete, and it kind of puts that indentation there, but you also have the cracks going out from the point of injury. You run into the same issue with bones. Twisting forces are common, especially to the anterior cruciate ligament or the medial cruciate ligament in the knee. Your knee is only meant to move in one direction. The knee and the elbow are both one direction joints, but your knee, especially because we change direction, we don't just walk in a straight line. It's real easy to damage those joints. And I know that I said them the way that they actually um, are spelled out, but you guys have heard those before. You may not even realize it. If you've ever heard of an ACL or an MCL tear, that's what that is. High energy produces severe damage to the skeleton, surrounding soft tissue, and vital internal organs. A lot of times, could be anything from a car crash to a gunshot wound. Anything that comes in with a high velocity will cause this. And a significant MOI is not always necessary to fracture a bone. You can do it with some medical conditions that are out there, osteoporosis, for example. You may not necessarily need to be hit very hard to have a problem. You really see that in your elderly. All right, for fractures, a fracture is a break in the continuity of the bone. Doesn't necessarily mean you broke the bone in half. It's just you splintered it. You created a crack. Any kind of damage to the bone would be considered a fracture. So this is usually caused by an external force. Sometimes it can occur because we tried to pivot too hard on our knee, landed wrong on our foot, that kind of thing. There's no difference between a broken bone and a fracture in the field, especially if not if the integrity is not 100% there, then the bone is technically broken. X-rays, a lot of times, most people don't usually break their bones into two pieces. Most of the time, they put a shearing force on it that went in a way that caused part of it to splinter off. That's why sometimes a broken bone doesn't always take as long to heal as what people think. Potential complications of fractures include compartment syndrome. Remember, you're going to have that swelling. And if your skin and your muscle can't expand to allow for it, that swelling's got to go somewhere. If it can't come out, it's going to go in, and it could pinch on nerves, blood vessels, and actually cut off blood supply to things further distal to the injury. Let me make sure I'm in the right spot. Your first priority is to determine whether the overlying skin is damaged, and what that's going to do is determine whether or not you have an open or a closed fracture. If it's open, that means you have bone sticking out the skin. A closed fracture means that your injury has happened. You may not have a break in the skin, so you can't see it. Open fractures are obvious. there's blood loss, there's bone sticking out, that kind of thing. So you can look at it and be like, that's a broken bone, you know. Um, Closed fractures, not so much. They may have some swelling, they may have some limited movement, um, or limited strength, or any of that sort. But you may not be able to look at it and tell. A buddy of mine, back when we were teenagers, he was in a car accident, and right before the moment of impact, he locked his arms out on a steering wheel, and he actually broke all four of his forearm bones across both arms. He didn't know for about a week because he could still move his hands, he could still rotate them, pronate and supinate, he could still grab things. He just realized that it really hurt him all the time just trying to open his door. Anything that required twisting his wrist caused a lot of pain. And after about a week of being hard headed, 19-year-old guys, we're not the sharpest tools in the shed because we don't think anything could ever happen to us. He finally went to the doctor, and the doctor showed him the x-rays. He had almost broken all four bones completely in two. He almost had 8 forearm bones. They were all completely deformed, but somehow they were deformed just enough that they didn't actually push his forearms weird. So he could still operate. They weren't 100% breaks. They were just more or less major fractures, and it took him a long time to heal because there's a lot of bones. But it's not, closed fractures. You don't always see them right out the gate, and without an X-ray, we don't know. So those are the ones where you can look to the person and be like, I don't know, I can't tell you if your bone's broken or not. You're gonna have to get X-rayed to see that for sure. So let's go to the hospital. And again, depending on where the break is and what the problem is, they may need you to take them. They may be able to get a ride from whoever or even drive themselves. It just depends. And as you go through your career, you'll be able to help differentiate those. The first priority is determine. Well, I already said that. We already talked about open and closed. Fractures are also described by whether the bone is moved from its normal position. So a non-displaced fracture or a hairline fracture means that your bones are still in place. They're right where they need to be. There's just a crack somewhere along the bone. You definitely need an X-ray and a really good eye to see it. Sometimes it's even looking right at the X-ray, you may not see the break. A displaced fracture produces an external deformity or a distortion of the limb by shortening, rotating, or angulating it. Think about like your femur, and I haven't mentioned this yet, but if you wanted to know in the field whether or not somebody broke a femur, what's a really good way to tell? You don't need an X-ray or anything like that. You can look at the patient and be like, yeah, that leg's broken. Any ideas? Yeah, one leg shorter than the other. Exactly. Remember, your muscles only exist to contract, and they're held out in an elongated state by the bone. So if the bone breaks, there's nothing left to stop that muscle from condensing down. So if you break your femur, you have very, very large muscles. Your quads, your hamstrings, they all are pulling the knee up into the hip. So the broken bone, the leg with the broken bone is going to be significantly shorter than the leg without the broken bone. Now, that doesn't necessarily mean that the bones broke. It could be that they dislocated their hip. We don't know. But regardless, something is wrong, right? That's not supposed to be that way. So that's a part of it. And then you can couple that with your MOI. Motorcycle wrecks usually wind up being the femur because they get caught by the handlebars when they flip over. Um, Vehicle accidents a lot of times wind up being the hips. Your hips get knocked out, or your femur gets knocked out of its ball and socket joint. All right, so this is a slide that we were going to be on for what we were just talking about. Here's a couple of different breaks you can see. Um, you have comminuted, which is a fracture in which the bone is broken into more than two segments. Epiphyseal. So remember we talked about the epiphyseal plate. in kids. That's where their bones grow from, right? And that is if you're looking, let's see, none of these pictures really show it, but right between where the shaft, right where the shaft of the bone starts to meet the head, in a child, there's a plate of cartilage there. That's where the bones grow from. So when as they're getting taller, it's growing from that plate. As long as you don't break that plate, they'll heal up fine. The problem is once that plate is fractured or punctured in some way, it stops producing bone. It goes ahead and solidifies right where it's at. So if a child breaks the epiphyseal plate and they're 10 years old, um, whatever size their leg is or whatever that bone is at that point, that's where it's going to be. It may grow from the other side, but it's going to be shortened that because that damaged side is no longer going to produce bone. Green stick, this is an incomplete fracture that passes only part way through the shaft of the bone. Um, it would be like the second one in this picture if that fracture didn't go all the way across. Both of those, the epiphyseal and the green stick, occur in kids. You have an incomplete fracture that does not run completely through the bone as well. Oblique fractures are like the bone is kind of broken at an angle. And then your pathologic, this is a fracture of weakened or diseased bone, and it usually doesn't take hardly anything to do this. Elderly patients, patients with osteoporosis, um, anything of that sort where their bones are weakened, calcium deficiencies can do this. Cancer can do this. It makes it to where the bones are so brittle that a very small impact can still break the bone. Spiral, this is a fracture caused by a twisting force. So you see this a lot of times in sports injuries. If it happens in young kids, a lot of times, unfortunately, I hate to say it, and don't take this and run with it, but child abuse will cause this. If they're getting their hands twisted and things like that, a lot of times that will cause that kind of an injury. And then your transverse, this is a fracture that occurs straight across the bone. The big example for this, especially as an EMT, is going to be your femur breaks. If a motorcyclist hits a tree, the bike stops, they go flying over the handlebars, but the handlebars catch their legs right about mid thigh, which is about how it usually winds up being. That would be a transverse break. All right, suspect a fracture if one or more of the following signs are present. Deformities. A lot of this stuff is going to be your DCAT BTLS. So your deformities, tenderness, guarding, mainly for their midsection, right? We talked about that. If you break your ribs, your body's knee-jerk reaction is to bring your arms in to give yourself more protection. You really don't do that with extremities. That's more of your trunk. You broke a bone in your ribs, or you took a real big hit to your abs, which I know that's not skeletal, but still same rules apply. You may see some guarding. Swelling. With any kind of traumatic injury, you're going to see swelling. Rapid swelling usually indicates bleeding from the fracture and is typically followed by substantial pain. All that liquid has to go somewhere, and it's going to start displacing muscle, displacing other organs, and especially if there's blood in it. Blood's an irritant, so it's going to hurt. Your patient they'll be in some pain, and a lot of times the pain is coming from the fluid, not necessarily the bone break. Bruising. If it takes an impact to break the bone, imagine that you get hit all the time. As kids, I know as a kid, I had bruises for days, all the time. I couldn't get rid of one bruise before I got another one right on top of it. Like I think I'm surprised my teachers didn't think I was abused as a child as much as I came to school with bruises all over me. Fractures are almost always associated with ecchymosis of the surrounding tissue. That is your bruising. Sometimes it can take a little while to develop. It depends on how fast that blood is starting to pool underneath the skin. So, you may already start to see bruising by the time you get there. They may be in the hospital by the time they start to bruise. So just keep that in mind. If you already see it, that just tells you that they've already got some major blood loss in that area. Crepitus, know that word. Um, that is grinding of bone against bone. Typically, you're going to see that on skull injuries, hip injuries, where you've got large flat bones that are fused together. They're not normally moving. If they break in those areas, when you go to do your head to toe and you're doing the whole 4-point push pull, which we'll show you at the boot camp, um, if two bones start to grind against each other, you're going to feel it for one thing. You're going to feel weird in your hands, and you might hear it. So that's crepitus. False motion is a motion at a point in the limb where there's no joint. If you if your leg is bending 3 inches above the knee, that's false motion, right? That you have created yourself a new joint that doesn't belong there. Exposed fragments, these are open fractures. So if a bone is sticking out of the skin, that would be an exposed fragment. Pain is definitely a part of this. Like I said, for closed fractures, usually the pain is because of swelling. If it's an open fracture, once your bone is exposed to air, it activates those nerve endings that are attached to it, and it hurts like hell. That's usually when somebody says that their bone hurts. That's why, like, if you give an IO, well, y'all won't, but if an advanced provider gives an intraosseous needle to somebody to try to give them fluids, the needle actually doesn't really hurt. I mean, it's like a shot. It hurts at the skin, but they don't hurt at the bone. What makes them hurt at the bone is when you start trying to shove fluid through that needle and it's displacing all those bone cells. Um, that's when they start saying that the bone hurts. So, keep that in mind. As long as the bone is inside the body and there's no air getting to it, typically the bone doesn't create pain. And then a locked joint. This is a joint that's just locked into position, difficult and painful to move. You see this a lot in the jaw. If somebody gets hit and dislocates their jaw, you can see this at any of your pivot joints, so like your knee, it may lock into place, your elbow may lock into place. Your ball and socket joints, you usually don't see those get locked up. Usually they just have limited motion in a certain direction, but you may still get some movement out of it. Just be careful. You don't want to sit there and, hey, look, I can still do this with your arm for a patient, because you may wind up ripping up blood vessels and stuff like that. And now you got all kinds of new problems that weren't there to begin with. Moving into dislocations. This is a disruption of a joint in which the bone ends are no longer in contact. So we're talking about any movable joint. Most common one that at least I've seen is a dislocated shoulder. There's so many things that go into your shoulder joint. You have multiple muscles, multiple bones. Unlike your pelvic girdle, you don't have just a bunch of fused bones held together for your femur to stick into. At your shoulder, you've got three bones, four if you count your humerus itself, and the muscles that hold it all together. It's interesting how your shoulder joint is put together, but because there's so many things that kind of play into it, your shoulder joint's actually really not that strong. If you put a load on your shoulder at the wrong angle, you really run the risk of hurting it. Anybody that's ever worked out in the gym, you'll never do shoulder exercises with a weight anywhere near what you would do squats and bench presses with. It's just, there's no way. So I highly, 0 of 10 would not recommend trying that. Supporting ligaments are often torn, usually completely when this happens. This is not a partial tear. This allows the bone ends to separate completely from each other, and a lot of times once that happens, the actual ball of the extremities bone will fall out of its place. A fracture dislocation is a combination injury at the joint. So this is, you both fractured a bone and dislocated it. Usually this involves one or more bones. This is definitely a surgery waiting to happen. There's not a lot we can do with this. When we're faced with this, our job mostly is just stabilize it, get them to a hospital. Try to make sure that they still get blood flow to their extremities past that, wherever that injury is at. Sometimes a dislocated joint will spontaneously reduce or return to its normal position before your assessment. I have actually had somebody dislocate their jaw, and when I got there and introduced myself to them, because that's when you get into the field, a lot of your primary assessment is done just by introducing yourself to your patient. He hadn't tried to say anything prior to me getting there, but when I introduced myself, he tried to say his name. And when he did, it just, I mean, he didn't like it. It hurt him. But his jaw popped back into place and he was able to talk. And that actually fixed the call. I didn't have to do anything after that. But every now and then you'll see that happen. Or if you've been on movies, or if you've seen movies where they're trying to reset this guy's arm into his shoulder joint, that's real. That can happen. Um, there was a football player this year that actually like almost flipped his patella backwards, and just right there on the field, he just reached down and flipped it back the other way. And I don't remember who it was. I think it might have been Patrick Mahomes or somebody, but um, that's some gruesome thoughts for you for the day. Some signs and symptoms of dislocated joints are similar to those of a fracture. So you're going to see it. All right. You have a marked deformity. Something is not like it needs to be. One leg's shorter than the other. The jaw won't close or it won't open. It's out of it looks like it's off its track, that kind of thing. Swelling is big. Pain is big, especially if they try to move it. Tenderness on palpation. So if you poke it, it's going to hurt. Try not to do that too much. And then virtual complete loss of normal joint function. Whenever you dislocate something, typically you can't move right anymore because you don't have that anchor point in place anymore. And then numbness or impaired circulation to the limb or the digit. And that's what we concern ourselves with. We don't want them to not be able to feel it or get circulation past it, because when that circulation is impeded, everything past it's going to start to die, right? It can't get blood flow, means it can't get oxygen. So when we get to the point of dealing with these things, that's what we're concerned about. That and some, pain relief, obviously, if they're struggling with that, because that just messes with their vital signs. Can anybody tell me the difference between a sprain and a strain? Which one affects the muscle? Yes. Okay. Sorry, I didn't see it. So a strain affects the muscle. You've strained your muscle. A sprain actually affects your joints. So sprains can range from mild to severe. The most vulnerable are the knees, shoulders, and ankles, because those are joints that aren't typically meant for a heavy load, or at least um, a load that hits in a different angle than what they've been braced for. So they're more likely to have that problem. After the injury, the alignment generally returns to a fairly normal position, and unless you've actually done some damage to the ligaments, it heals pretty quick. Um, but yes, if you remember what I said, less blood supply means that if you have done damage to the ligaments, then it's going to be a little bit longer before you heal. Sprains don't usually involve a deformity. Joint mobility is limited by pain and not joint incongruity. So you're not necessarily going to deal with a deformity. The problem is that it just hurts to move, and that's why they're not able to do it that much. Following signs and symptoms of a sprain, you have an unwillingness to use the limb, swelling and bruising. Pain prevents the patient from moving or using the limb, and there's an instability of the joint. It may not be out of place, but it's susceptible to it. So if somebody sprains their ankle, and the problem is actually in the joint of the foot, we really don't want them walking around on it, because they could dislocate the joint, do more damage, that kind of thing. So we'll put them in a boot, give them some crutches, and have them stay off their foot for a few days. A strain is a pulled muscle. You can get these pretty much anywhere, and they hurt pretty bad, actually. It occurs because of an abnormal contraction or from excessive stretching. So, trying to think of any kind of scenario that's not a gym rat scenario. But if you hyperextend an arm, be it that you were in an accident and let's say that your arm got pinned up behind you. If your arm gets stretched too far behind you, if you were to actually take your arm out to the side and then try to pull it behind you, you'll feel a real big stretch on the outside of your chest. If you got caught on something and it did that too hard, you would strain the muscles of your chest because you stretched them out too far. That's what these are. These happen a lot in the lower legs from running. Football players will get it when they're trying to change direction pretty fast. They don't do any damage to their joints, but they might roll their ankle. And even though their joint came out of it fine, that roll might have hyperextended one of their muscles, and now they've got a strain. So unlike a sprain, no ligament or joint damage typically occurs. And often no deformity is present because these are just problems in the muscles. There's no broken bones, there's none of that stuff is there to make the injury that apparent to you. Amputations, that's just pretty. And I say that with complete sarcasm. An amputation is an injury in which an extremity is completely severed from the body. That includes the bone, if there's a bone there, anything. If it's still attached, it's an avulsion. If it's completely off, that's an amputation. And this injury can damage every aspect of the musculoskeletal system, from bone, ligament, muscle, blood supply, all that stuff gets ripped. Orthopedic injuries can lead to numerous complications, not just those that involve the skeletal system, but also systemic changes or illnesses. It's essential that you don't focus all of your attention on the skeletal injury. When we get you to boot camp, we start giving you scenarios. We're going to use muscular skeletal injuries as a distractor. I'll go ahead and give you guys that tip now. Yes, you eventually will have to deal with them, but we may hide a more serious injury in your patient than what that is. So I don't want you to go, holy crap, I need to take care of this leg because it's twisted around backwards and he's chewing on his foot. Don't get caught up with stuff like that. Remember your assessment, which we're going to run through it again tonight. Get your primary out of the way, get the life threats out of the way. The bone breaks and messed up joints, you'll get to them, but don't let it distract you from the stuff that's really important. The likelihood of having a complication is often related to the strength of the force that caused the injury's location, and the patient's overall health. To prevent contamination following an open fracture, remember this is where the bone's coming through the skin. Brush away any obvious debris and then apply your bandage. Don't enter or probe the open fracture site. Don't put your fingers in there. Don't try to push the bone back in. Keep in mind, if you have a bone sticking out of the skin, that bone end is going to be sharp, right? It had to be to poke itself through the muscle, out the skin. If you try to manipulate the joint and get that bone back inside of them, if it didn't tear up blood vessels before, it's at all that risk of doing it again, or doing it the second time around. So if they have a bone sticking out, stabilize it like it is. Like it says, try to knock any dust or dirt off of it, but your patient's going to be in extreme pain. So be careful doing that. Stabilize it as best you can, like it is. Don't try to put it back in because you don't want to cause any more damage than what's already done, and then get them to the hospital because they're going to need surgery for that. Long-term disability is one of the most devastating consequences of an orthopedic injury. If it's a broken leg, they're not really so much going to have long-term disability. That's not normally something that would cause that, because you can recover, even if you need something like physical therapy. You can pretty well get back to where you can walk again. Injuries to your spine, to your vertebral column, injuries to your skull, that could have also caused those secondary damages to your brain, to your spinal cord. Those things will cause long-term disability. So if you're worried about an orthopedic injury to the neck, for example, it's really not so much that we're worried about the bone. I mean, big whoop-de-doo, that'll heal. We're concerned about what that dislocated or broken bone is going to do to the organs that it's protecting or supposed to protect. You can help reduce the risk of, or at least the duration of long-term disability by preventing further injury. So again, don't poke the bone back inside. Stabilize it as best you can, reduce the risk of wound infection, especially if it's a wound that has to do with their skull or vertebral column. If that gets infected, that infection usually goes straight to the brain, and then now they've got life-threatening issues like meningitis, for example, or any other infection that can get in there. Minimize pain by using cold or anesthesia, cold packs, that kind of thing. Um, we are very limited. We don't have a lot of analgesia that we can do. So if you need medicine to calm somebody's pain, that would be an example of when you would call a paramedic as an additional resource at the beginning of your assessment. And then transport and get the patient to the appropriate medical facility. Because this requires surgery, and usually the bone breaks themselves are not they're not going to make your patient unstable. So if that's the worst of your injuries, if they're alert, say they've just got a mangled up leg, they're stable enough you can bypass the band-aid station and stuff like that. Go ahead and get them to a trauma center, because if you were to, like, let's say you're in Poplarville and you got a guy with a mangled up leg, but you have no problem he's stable, right? You have no life threats, you've controlled his bleeding, all that stuff. He's just screaming in agony because he has a flattened leg. If you roll up the Poplarville ER, and I use that term loosely, they're going to look at you and be like, "What do you want us to do? He's stable. We don't have a surgeon here." So in these incidents, go ahead and go to your nearest trauma center. For you guys in South Mississippi, yeah, Forest General. There's a few on the coast. You know, you got some in Louisiana, obviously. I think most all of your Ochners, I believe, are trauma centers. They're pretty big. Yeah, why is the patient here? I had somebody ask me that when we brought a code in. Of course, that was a long time ago, and they probably aren't there anymore. But yeah, if I'm coming in I'm doing chest compressions, that's why we're there. Anyway, don't get me started on that. All right, so assessing the severity of the injury. We mentioned the golden hour or the golden period at the beginning of this course, back on like day 1 or day 2 of class. So it matters here. All right, it's not just critical for life, like we talked about before, but also for preserving limb viability, especially if there's torn blood vessels, torn nerves, that kind of thing. The longer they go without corrective surgery, the less likely they are to get full functionality back of whatever's been injured. In an extremity with anything less than complete circulation, prolonged hypoperfusion can cause significant damage, and that can actually be life-threatening. If enough cells die because they lost their blood flow from a broken leg, then when they do finally get it restored, all that necrotic tissue from those dead cells is going to re-enter circulation, and it's going to be pumped all over the body. Now they've got systemic infection, sepsis, to pretty much every organ in the body, and a lot of times they don't walk away from that. So be careful. If you've got a patient that's got limited blood supply, that can pretty much become your biggest concern. Even though they didn't lose any blood, just that break has, pinched the vessel and it can't get blood flow past it or whatever. And you'll know because when you're doing your assessment, you can't feel a pulse past it, right? If there's a broken arm and you go to check their wrist, you don't feel a pulse. But you know they've got one because they're awake. So they're not dead, but you just can't feel it in that extremity. Your biggest concern is trying to get blood flow back to it, because if all those cells in the arm die, it may wind up being that they have to amputate the arm because they can't chance of restoring blood flow to it with all that necrotic tissue. Just remember, most of your injuries aren't critical. It's just what happens if you don't get them fixed. That's when it becomes critical. You can use a musculoskeletal injury grading system. It's in your book to identify critical injuries. I don't know if that's on here or not. Doesn't look like it. So just check your book. You're not going to be graded on that. There won't be any questions about your priority system. But the big thing is just know, like, a complete deformity, a complete muscle break, that's worse than, say, a strain, for example, right? So that's what that's getting at. Everything we've talked about some critical things, and we talked about some things that you could you kind of want to look at your patient and be like, you called me for this? All right, before we go into patient assessment, let's take a break, 10 minutes. Be back at 5 after 7 and we'll continue on. All right, let's get back to it. So there's a big section of this that we're going to skip tonight, talking about the different types of splints and all that, just because we're going to do that when we get to the boot camps. Um, we'll do that at length because you're going to have to learn not only what's out there, but which ones go to what and how to use them, when to use them, that kind of thing. So it's much easier done in person. Like I said, I will lose myself trying to get through that part of this plan without being able to pull out a splint and actually show it to you and pass it around the room, put it together and all that stuff. But anyway, we're going to do the patient assessment, and then we're going to talk about different injuries that you can come across besides just broken bone. Always look at the big picture. Evaluate the overall complexity of the situation to determine and treat any life threats. Again, don't get that tunnel vision. All right. Don't be like, holy crap, this guy's leg is mangled, and that's what I need to go work on, and miss the fact that he's got a mouth full of blood and vomit and he can't breathe. You must be able to distinguish mild injuries from severe ones because the dislocated foot may look bad, but the broken ribs that are otherwise, the chest looks kind of normal with the shirt on it, the broken rib may get missed, whereas you went straight to the foot. But otherwise, your patient assessment is going to pretty much run exactly like they always have. So we're going to start with our scene safety, BSI, scene safe, paint your picture, get a look at your MOI, try to figure out if you need any help. Do you see anything with the MOI or the scene around you that makes you say, you know what, I need hazmat or I need paramedics or cops or any of that sort. Get that information. Consider the possibility when you look at your patient that they may have hidden bleeding. Just because it's not pooling up on the ground doesn't mean that they're not losing blood internally. For your mechanism of injury, be alert for primary and secondary injuries. Remember we talked about like the car accident, right? Car hits the tree, your body hits the steering wheel or the airbag, that would cause the broken bone. But beyond that, your organs are going to slam into your rib cage. If there's anything in a car, that could fly around, that kind of thing. So you've got other injuries to look at just based on how we move. All of our organs are just basically meat sacks floating around in some fluid. So they move a lot when we get hit in ways that we're not supposed to. Your primary assessment is just your life threats. So get a look at your patient's level of consciousness. If they're awake, great. That's going to make your treatment of their airway pretty easy. If they're unconscious, well, that sucks, and you're probably going to have to do an airway adjunct and bag them or whatever. But get their LOC, using the AFPU scale, are they alert, verbal, painful, or unresponsive? And then move into your actual ABCs: airway, breathing, and circulation. For your airway and breathing, fractures and sprains usually don't create airway and breathing problems unless the problem is in that area. Little else matters if the patient's airway and breathing are inadequate. Same thing with circulation, though. If they're bleeding out, stop the bleed. It doesn't matter if you open the airway. If they lose all their blood, there's nothing to carry the oxygen around anyway. Focus on determining whether the patient has a pulse, adequate perfusion, or is bleeding. So first of all, you want to make sure that the blood stays in the blood vessels. Secondly, you want to make sure that it's moving and that it's moving well. So feel for the pulse, make sure the pulse feels strong enough, and make sure they're not bleeding out on the ground. Give them oxygen. Anytime you have a trauma patient, go ahead and go straight to the high flow O2. 15 liters non-rebreather, that's okay. That's not your final answer for oxygen. That's just your first answer. When you get down the road to their vital signs and you look at their O2 sats and you find out that they're rocking 100%, we can dial that oxygen back. But if they, especially if they've lost blood, we want to give them more oxygen because they're already hurting from not having enough transport. We want to make sure that the blood they do still have in their system has more oxygen to work with. And you can always titrate it later on. And remember, if you're looking at your assessments, if you skip this, it's an automatic fail. That being said, I'm not going to fail you if you forget it and then come back to it. But if you get done with your assessment and you didn't give them oxygen, that's an automatic fail. Hypoperfusion and bleeding problems will most likely be your primary concern. So as long as they have the blood in their system and they're still breathing, then your circulation is usually good. If the skin's pale, cool, and clammy, freak out about shock. All right, get ahead of that. Don't let that get ahead of you, and maintain a normal body temperature as best you can. So cover them up. If you have to make any changes or any interventions at this point, if you had to do anything for your patient other than just check, they're a high priority for transport. All right. If you had to bag them, if you had to um, put a tourniquet on them, anything of that sort, they're a high priority for transport. Everything I give you in class will be a high priority for transport, but won't be the case always when you go out to the real thing. Obviously, people will call you for pretty insignificant injuries that they don't necessarily have to be in your truck to get to the ambulance, to get to the ER. A patient who has a significant MOI but their condition appears otherwise stable should also be transported promptly, because if it's a significant MOI, they may not be stable for long. Right? Remember, we do compensate for a while, so not a lot of BLS stuff in boot camp. No, actually, it's the other way around. Your boot camp is everything you're doing is BLS in this class. There's no ALS in this class. So if you go on to advanced EMT or paramedic, then yeah, and that's why the boot camps are longer, because you have more stuff to do. But your boot camps are just going to be BLS. Um, Not to say there's not a lot to do. There's a lot to do in BLS, and in fact, in trauma is about 90-10. 90% of it's BLS, even at the paramedic level. Only about 10% of what happens for trauma calls needs a paramedic. Patients with a simple MOI, say it's just, they fell, um, they were skateboarding and they fell, that kind of thing. They don't necessarily need to be transported that fast, if at all. Just give a good assessment, make sure they didn't hit their head, make sure they're not having any kind of altered mental status, that sort of thing, before you leave them to their day. Fractures can break through the skin and cause external bleeding. Unless it punctures an artery of some sort, usually that bleeding is not that bad. But depending on what gets ruptured as that bone is on its way out, the bleeding can be pretty profuse. So, take a look at it. If they have a bone sticking out and the bleeding is profuse, then take care of the bleed. If the bone's sticking out and they're losing some blood, but it's not much. It's just, a typical flesh wound kind of injury. You can leave it for a little bit, get to it when you get to that point of your assessment. For your history taking, get your medical history, your sample. Everybody gets a sample. Only conscious patients get the OPQ-RST. If you're in I know it says here OPQ-RST is too lengthy when ABCs require immediate attention. This goes back to my gripe with these slides. None of this needs to happen when you're dealing with your ABCs. Even if you look at your assessment sheets that the registry sends out, you have to get through your primary before you get to your secondary, and your history taking is in your secondary. So don't make the mistake of doing sample when you're still in your primary. That's an automatic fail. You have to do your primary assessment is a critical block that needs to be done only after you're seeing size up. So your seeing size up has to get right. Your primary assessment has to get right, and in that order. And then when you get to your secondary, you can play around with it. You can do your vital signs first. You can do your history taking first. I really don't give a shit. It's entirely up to you, based on what is in front of you. So if your patient's up talking to you, you can go ahead and get your sample history and everything. That's fantastic. If your patient looks like they almost lost their head because it's a vehicle rollover and they fell out, they got thrown out the vehicle, maybe sticking around to ask somebody a sample history is not the best thing for the patient. So when you get past your primary, you can arrange this however you want to. But your scene size up has to be exact, and your primary has to be exact. Those are most of your failures come from that. All right, for your physical exam, this is your head to toe. If significant trauma has likely affected multiple systems, then start with a secondary assessment of the entire body to make sure that you have found all the problems and injuries. Remember, your goal is to get them to the hospital if they're bad. But especially for trauma, we don't really know where the extent of their injuries are if we don't first take a look. So you want to know, okay, I need to get them in the truck. That means I got to move them. How can I move them without making injuries worse? You have to know what injuries they have. So get your head to toe then you can move them, because then you're going to know, well, I would like to roll them onto their left side, but they have a broken hip on that side. Maybe I should move them to their right, that sort of thing. The goal is to identify hidden and potentially life-threatening injuries. You're still keeping an eye, even though you've made it past your primary, you're still looking for things you might have missed. So keep that eye, even though you're working through your secondary, keep that eye. If you see something that would technically be a life threat, go back and fix it, right? Don't just pass it up. When lacerations are present in an extremity, an open fracture must be considered, even if the bone's not physically out of the skin. If it broke the skin, it could be an open fracture. Assess your neurovascular function. That is making sure that they can feel you. If you press on their foot, for example, can you feel me pressing here? Check their motor sensory. Can they move their foot against your hand? Have them do both. I mean, if there's a broken bone, then maybe don't try to have them like putting pressure on your hand or anything, but just see if they can wiggle their toes. Um, See if they can rotate their foot depending on what the injury is. The big thing is though is, can they feel you and can you find a pulse? Use your 6 P's of musculoskeletal assessment. You don't have to memorize this, but if you do, fantastic. It's pain, paralysis, paresthesias, which is numbness or tingling, pulselessness, pallor, and pressure. So it's pretty much everything about looking and feeling. Can they move? Can they feel? What do they feel? That sort of thing. All right. Next up is your vital signs. So get your baseline: pulse rate, rhythm, quality, respiratory rate, blood pressure, your skin condition, pupil size, and reaction to light. That's your neuro check. Don't forget those. If they're unstable, we're going to recheck those every 5 minutes. If they're stable, if they'll say they just broke their leg, but they're up talking to you, they didn't hit their head, they weren't really in a bad MOI, you can reassess every 15 minutes. It's entirely up to you at that point. Just remember, those are guidelines. If you feel like if 5 minutes is too long, if your patient is that unstable, you feel like 5 minutes is too long and you want to do it more often than that, then go for it. You're only going to benefit your patient. In a critically injured patient, secure the patient to the long board for transport. But again, remember, we don't just throw them all on there anymore. That's going to be for the patients that have a hip injury, a lot of bad leg injuries, lower back pain, that kind of thing. They're going to get the long board. Otherwise, could just be a C-collar and get them on the stretcher so that they can be comfortable. It just depends on what the injury is. But your main goal is to stabilize most of your injuries. So a lot of times the position of comfort is the best thing. It keeps they're not in excruciating pain, which keeps their vital signs in check. They're not going to hyperventilate because they're not hurting as bad. And if there is just nothing you can do for pain, no matter what position you put them in, they're screaming in agony, call a paramedic. Let a paramedic come out, give them some ketamine, send them on a trip, and take them to the hospital. All right. So for this portion, this is what we're going to skip. This is basically how to do the different splinting techniques and the different things that are out there. Again, it's much more easily taught in person at the boot camp. So we're going to take this portion of the chapter and we're going to move it to the hands-on when we all meet in January. Let me get to the right slides here. Okay. All right, so we're going to talk about specific injuries that you may come across for different parts of the body. Once we do this, I believe we have another portion of compartment syndrome to talk about, and then we'll be done for the night. So let's start with the shoulders, injuries of the clavicle and scapula. Your clavicle, which is your collarbone, right? That's the front. That's the long, slender one at the top of your chest. There's 2 of them. It's one of the most commonly fractured bones in the body, especially if you're a football player or anybody that has a risk of getting hit in their shoulder. A lot of times we see this in kids, we see this in sports. A patient with a fracture of the clavicle will report pain in the shoulder and will usually hold the arm across the front of the body because it allows the muscles that run across that bone to not pull on it so hard. They're going to be holding kind of in a guarded position, keeping their arm in place. So when you deal with this, you're going to try to stabilize the joint like it is. Now, I know we haven't gone over triangle bandages. This would be a point where you would use it, and we'll show you how to apply it when we get to boot camp. But that's what you normally see. If you've ever seen anybody with their arm kind of up in a sling that's wrapped around their neck or whatever, and it's just kind of hanging, that's what that injury would be good for, or what that immobilization would be good for. There is swelling and pain, tenderness, and everything at the clavicle, so you're going to see that little bulge around that bone where they're starting to swell. And because the clavicle is subcutaneous, the skin will occasionally tint over the fractured fragment. You can see the bone, even without an injury. You can see that bone there, right? So if it breaks, you'll actually be able to see the deformity. 5 pounds of pressure, yeah, I think so. It's a very small bone. It's not meant to be hit. It really doesn't take. I don't know if it's actually 5 pounds, but I know it's not much. If you take a direct hit to the clavicle, it really doesn't take much at all to break it. All right, fractures of the scapula. Now this is your shoulder blade. This is on the posterior side. This is much less frequent because the bone is well protected by many large muscles. If you think about it, it's buried under your lats, your back muscle. The posterior side of your deltoid, which is your shoulder muscle, your traps, all that stuff sits on top of your scapula. And because of that, your scapula by design is not meant to move like away from where it sits. Think of it like a plate. That plate is sitting on top of the table and you can slide it, but you can't pick it up. Because of that, it absorbs impacts very, very well. It's really hard to break that bone, but it can happen. High energy weapons like bullets can do it. If they get stabbed in the shoulder blade, they can do it. But these are almost always the result of forceful direct blow to the back directly over the scapula. And it pretty much has to be right where the bone's at for it to do damage. If you see this, give them oxygen, try to stabilize as best you can, just with, like I said, with the sling and swath, and we'll go over that when we get to the boot camp, and then get them to the hospital. The joint between the outer end of the clavicle and the acromion process, it's called your AC joint. I'm not going to make you guys know, but it's right there on the slide. Acromioclavicular. That is that's your shoulder joint. It's where the bone, where the humerus of the arm fits in. A lot of times this gets injured during sports. These fractures can be splinted effectively with a sling and swath. And these pictures is what I'm talking about. So all of your shoulder injuries, you're going to do that kind of a splinting for, or that kind of a stabilization. And we'll show you how to do that at boot camp. For dislocation of the shoulder joint is where the head of the humerus meets the glenoid fossa of the scapula. So remember, you have your scapula in the back, your clavicle in the front, a couple other, you have your humerus of your arm, and a bunch of different muscles form that joint. The glenoid fossa joins with the humeral head to form the glenohumeral joint. And because there's so many different things that come together here, and they don't fuse, they just kind of hang out. They're tied together by ligaments. It's really easy to dislocate this if you do something wrong. If you pull, say, like if you pull it, I'm pretty sure. Are you talking about pulling on the clavicle? The clavicle technically doesn't move. I mean, it does a little bit, but it's more of just a stabilizer. But it doesn't take hardly anything. A lot of the times, injuries to the shoulders that involve movement are going to wind up being the dislocations. To break the bones usually just takes an impact. Anyway, shoulder dislocations are extremely painful. There's a lot of nerve endings that run through there. There's a lot of blood vessels that run through there. The patient will guard the shoulder, just like how if they broke their bone, they're going to guard it. They're going to pull their arm in, try not to move it because it hurts real bad. So we're going to do the same thing as we would with a shoulder break. You're going to use a sling and swath to hold their arm in place. Some patients may report numbness in the hand, especially if that bone sliding out of place starts to put pressure on nerves. They're going to lose feeling down there. Stabilizing an anterior shoulder dislocation is difficult because any attempt to bring the arm in toward the chest will produce pain. The minute you try to start doing this, your patient's going to scream at you. It usually doesn't even work. You must splint the joint in whatever position is most comfortable for the patient. So that's our job, right? We're not resetting the joint. Just stabilize it as best you can. What I'll do is I'll go ahead and put them in the sling. That's the part that goes around the neck and holds their arm up. And then I'll manipulate it a little bit toward the front or maybe down a little bit, depending on what they tell me feels the better. I'm not going to say feels good, but just feels better. And then wherever that's at, I'll make the swath hold it in place at that particular spot so that it doesn't move around any more than it has to. If necessary, you can place a pillow or a rolled blanket between the arm and the body. Sometimes that helps because if it feels better for them to have the arm raised a little bit, that's the easiest way to do it. All right, elbow injuries. Fractures and dislocations often occur around the elbow, and the different types of injuries are difficult to distinguish without an x-ray. A lot of these, that's going to be the case for most of our bones. Unless they're sticking out the skin, we really can't see them. Fracture of the distal humerus is really common in kids. This type of fracture is also known as a supracondylar or a intercondylar, intercondylar. And then frequently the fracture rotates rather than is just like a straight through or anything. So it's going to produce a deformity. A lot of times you're going to see the kid or even the adult, it's going to look like they have a second elbow, like right above their actual elbow. They're going to look like they have a second movable joint right there. Swelling occurs rapidly and is often severe. Where do you see this at? Oh, that looks painful. I know you can't give me patient information, but like what happened? Wow. Hmm. So I was okay. So the cops were out there too, obviously for that. Yeah, that sucks. And that's for a grown woman too. That's actually not common for adults. The bones usually better built. She must have landed just right. Damn, that sucks, dude. All right, continuing on with the elbow. For dislocations, this type of injury typically occurs in athletes, and it really doesn't happen that much in kids. Kids are more likely to just break the humerus. Dislocating the elbow is more of an adult thing. The ulna and the radius are most often displaced posteriorly, so they're going to push back toward the actual, like what we consider the elbow, the tip of that process. The posterior displacement makes the olecranon process of the ulna much more prominent, so it's going to stick out. If you look at this guy's elbow in the picture, um, besides the fact that it's very much bent the wrong way, you can see how much more prominent his elbow looks. It almost looks like he's got a golf ball in there. Um, that's part of it because the bone's dislocated and moved out of their socket. As with a fracture of the distal humerus, there's a lot of swelling, significant potential for vessel or nerve injury, and a lot of pain. For a joint sprain, this diagnosis is often mistakenly applied to an occult non-displaced fracture. We don't know in the field. So if that's you, if you try to call it a fracture, then who cares? You did the best you could, right? They'll figure out the details of it in the hospital. Fracture of your olecranon process, which is your elbow, what we consider the elbow, that bony prominence, and your ulna. This fracture can result from direct or indirect forces and is often associated with lacerations and abrasions. I don't know about y'all, my elbows stay skint up. Like that happens so much I don't even really realize when it does it anymore. I'll just be like, huh, I'm bleeding. Don't know what happened. If when you get this, when these fractures happen, your patient will be unable to extend the elbow, so they're going to have their arm curled up and they won't be able to straighten it out. Fractures of the radial head. These are often missed in diagnosis because they don't really form any kind of deformities. All they do is they make it hard for your patient to rotate their wrist up, like pronate, supinate their palm. But a lot of times we can't find that in the field. So we usually attribute it to the ulna being the problem, and then they find it in the hospital when they actually run X-rays. So if this is what you've got, you have to be careful because all their blood vessels and all their nerves run through this area. But sling and swath is perfect for this. For the same thing, you're stabilizing the elbow just like you would stabilize a shoulder. If you find good strong pulses and a good cap refill, splint it like you found it. If you try to move it, you may lose those. So keep that in mind. Um, Further care of the patient must be dictated by a physician. Get him to the hospital. If the limb is pulseless and significantly deformed at the elbow, you can try to put manual traction in line and see if you get the pulse back. But you get one attempt. All right. So if their arms kind of hanging and you see that deformity, you can put pressure up on the humerus to stop the shoulder from coming out. Once you've got that pressure in place, you can grab them by the hand and pull and kind of stretch the bones apart a little bit. You're not ripping the arm off, but just like maybe a half an inch to an inch, and see if you can take pressure off of their arteries to get blood flow restored back to the hand. If you can't, splint it like you got it, and then get them to the hospital and let the hospital know that you were not able to restore a pulse. All right, fractures of the forearm. We're still dealing with your ulna and radius. Um, these are common in people of all age groups, but we usually see them in either kids or older people. Most people in their normal adult ages don't have this problem. Usually, both bones break at the same time, like I was telling you about my friend John. He broke both ulnas and both radiuses in one fell swoop. An isolated fracture of the shaft of the ulna may occur as a result of a direct blow to it. I think like a nightstick fracture. So if they called it that because when cops used to carry nightsticks, they go to swing at somebody and you put your arms up to protect yourself, the stick hits you in the forearm, would break those bones. The term silver fork deformity is used to describe the distinctive appearance of the patient's arm. So it kind of resembles the fork. To stabilize a fracture of the forearm or the wrist, you can use a padded board, you can use an air splinter or vacuum, but if it's an open fracture, obviously anything that you inflate would not be a good one because it could pop the splint. If possible, elevate the injury above the heart. It'll help slow down swelling. And that's big on the forearm. It'll be also big on the lower leg to fight that compartment syndrome, which is what we're going to end talking about tonight. Injuries of the wrist and the hand. These are the easy ones for us because we just stabilize them like we find them. Really not a lot we can do. We can't diagnose these. We wouldn't diagnose anyway, but we can't really look at it and say, yeah, it's broke, because it's not something that would cause a real deformity, like say if you broke your femur. So they need to get x-rays. Dislocations are usually associated with a fracture. Hand injuries will vary widely depending on what happened. So some are potentially serious consequences. It depends. Because of the fingers and the hands are required to function in such intricate ways, any injury that's not treated properly may result in permanent disability. They may lose the ability to control their hand. Remember, the muscles that actually make your fingers curl are in your palm. I'm sorry. Yeah, they are. They're in your palm. So they're not actually in your fingers. If you take a hit to your palm, it could make you not be able to have the dexterity of closing in your fingers and making a fist and all that. So keep that in mind. Depending on what happens to their hand, you could have some problems all the way down to the fingertips. All right. We're going to kind of I don't think we're going to go back to it. Not really going to talk so much about injuries to the ribs, because we beat that to death when we dealt with chest injuries. So just remember what we said about the ribs, or yeah, the ribs before we go into the pelvis. Remember they're shaped kind of like the letter C. The nerves and the vessels run underneath them. So when those break, we have more concern about our vasculature and our heart and lungs. We're not so much worried about the ribs themselves. For the pelvis, fractures of the pelvis often result from direct compression in the form of a heavy blow that literally crushes the pelvis. Your pelvis doesn't have any joints in it other than, well, actually, your pelvis does not have any joints in it. They're all fused. Um, they don't, you don't dislocate your pelvis basically. So, and these bones are huge. The only real way that they break is to have some kind of a massive blunt object hit them, be it something fell on you, or there are cases where you might be the heavy object and you fell on something. There's a way to break your pelvis riding a horse or a motorcycle. If you slam down too hard, you can break your pelvis at the bottom center. But it's the same thing. It's just that your body actually wound up being the heavy impact, not the thing you landed on. Not all pelvis fractures result from violent trauma. Some pelvic fractures can happen in childbirth. Some pelvic fractures can happen from um, disease, and then possibly overextending something, pulling a muscle can cause some problems there. It's really not common to have an open fracture. A lot of times these fractures are hairline fractures, or um, kind of like a spider web fracture if something hits you dead on. Remember, like I talked about, if you drop that ball on concrete where it hits and kind of spider webs out, you can have those kind of injuries, but they don't typically cause open fractures. The skin's not normally broken. You should suspect a fracture of the pelvis in any patient who has sustained a high velocity injury, so car versus tree, and complains of discomfort in the lower back or abdomen. And if this is what they're telling you, this is exactly the time that you want to grab the longboard. This is the time for that, or the scoop stretcher, or something of that sort. This isn't really what we would just put a collar on them and throw them on the litter, because our problem is down at the hip area. Deformity or swelling may be very difficult to see because there's so much meat already there with your abs, your legs, all that stuff. You may not notice the deformity. The most reliable sign is going to be simple tenderness or instability. So when you get to this part of your assessment, if you're going to assess somebody's pelvis and hips, you grab them by the hips and you do a little bit of a squeeze and a small, very small rotation. You shouldn't actually feel any bone movement. If you do, that tells you that your pelvis is fractured. Assess for tenderness, which we'll go over how to do that. And then if there's been any injury to the bladder or the urethra, the patient will have lower abdominal tenderness and may have evidence of hematuria or blood in the urethral opening. So this is what you're doing. If you look at the pictures, they're pressing in. You press in from the sides, press in from the front, and then you can press one side or the other instead of doing both at the same time. If you feel any kind of movement that doesn't move the whole pelvic area at the same time, because it should be one piece, then you know that you've got a broken pelvic girdle in there somewhere. This pubic symphysis in the center picture, that little bitty spot in the bottom center of your pelvis, that's what usually breaks on motorcycle accidents, horseback riding accidents, that sort of thing. It's a very small spot. And from its normal location, we don't normally get a break there. But if you're riding on something, that could cause that break. And that's pretty painful. That also means that your hips are going to be unstable and able to flare out. So imagine If you were to kick your feet apart, your legs spread out, but your hips stay together. If that piece breaks and your legs come out, they'll actually drag your hips open with it. And now we run into much other, a lot of other issues. Um, if that's what you think is broken, then what we usually do is we take either like a bed sheet or something of that sort. We'll wrap it around them and we'll cinch it down, kind of like a belt, but it's just to build stability to their midsection right there. For dislocations of the hip is very stable. It's not like your shoulder girdle. It's not like you've got a bunch of things kind of coming together and then making a sort of socket. This is a bunch of fused bones, and then your femur just kind of fits into it. So it takes a pretty good bit to do this. Now, that being said, it's easier to dislocate your hip than it is to break your femur. The reason why they are not pushing for traction splints and training so much for EMTs anymore is because you really never use it. Most of the time, unless you catch your femur just the right way, the mechanism of injury is going to cause you to dislocate your hip, which will it'll actually divert a lot of the shock, and you wind up not breaking your femur. So, or if you do break your femur, you probably broke your ankle as well. You may have broken your tib fib, messed up your knee, messed up your hip, any of that stuff, and all of those um, are contraindications for the traction splint. So it's pretty rare that you use that. You should suspect a hip dislocation in any patient who has been in an automobile crash and has a contusion, a laceration, or an obvious fracture in the knee region. Posterior dislocation of the hip is frequently complicated by injury to the sciatic nerve, and they will be in excruciating pain when that happens. The nerve runs right behind the hip, so if the injury is anywhere in that area, you're going to know. They're going to be screaming. That nerve pretty much controls everything about that leg. You've got a sciatic nerve on one for each leg. It controls the activity of the muscles, and a lot of your actual pain receptors run through there too. So if you know anybody that's got sciatica, it hurts. It's not something that feels really good. A buddy of mine um, has that problem chronically. You should have seen the look on his face the other day when he came by and tried a massage tool that gave him a little bit of relief, and he was like, "Oh my God." He couldn't believe it. It's been so long since he had a lack of that pain that I thought he was going to cry in my living room. Dislocation of the hip is associated with very distinctive signs. Your patient will have severe pain in the hip and will strongly resist any attempt to move the joint. They're going to fight you if you try to move their joint. The lateral and the posterior aspects of the hip region will be tender. And occasionally the sciatic nerve function will be normal at first and then slowly diminish. And with that's going to come increasing pain and decreasing functionality of the leg itself. As with any other extremity, don't attempt to reduce a dislocated hip in the field unless med control directs you to do so, and it usually winds up happening if you can't find a pulse. So splint the dislocation in the position of the deformity, splint it like you found it. Place the patient supine on the long backboard, support the affected limb with pillows and rolled blankets, secure the entire limb to the backboard with long straps, and then provide prompt transport. And I'll say this too, when we say splint the dislocation like you found it, one of the first splints I ever had to put on, a guy had fallen on his foot and he straight up broke his ankle. I mean, broke it like his leg was pointing in one direction and his foot was pulled 90 degrees to the left and pointing toward his other foot. This is and the reason I bring that up is because if you go to work somewhere or you want to build your own medical bag or something of that sort, you would think that cardboard splints are like the cheap way to go, and in a way they are, but they're very useful because for situations like that, all we had to do was cut a piece of the splint off with our trauma shears, and then that allowed an opening for his ankle to stick out the side of the splint while we splinted everything else in place. An injury like that would not really have been able to have been secured in any other kind of splint that we have out there. The air splints and all that wouldn't have done it. We could have splint his leg, but his foot would have been in the way of us trying to stabilize his ankle. All right, guys, give me a second. I'm going to put you on mute. Hey guys, take about a 5-minute break. We're almost done. I just got to take care of something real quick. All right. Sorry about that. Had a there was no way y'all were gonna hear anything I was saying with all the stuff going on around me. So let's go ahead and finish this out. Fractures of your proximal femur. Remember we talked about proximal and distal when we refer to your extremities, going way back to the first module of the course. Proximal is closer to the trunk. So we're talking about the upper part of the femur, kind of close to the hips. Fractures at this point are pretty common, especially in older people and patients with osteoporosis. A lot of times when patients fall, they may not break their hips. They may wind up breaking this part of their femur. The break goes through the neck of the femur and the yeah, good luck. Anyway, the break can go through the neck of the femur, and that one thin part that goes from the neck or from the shaft of the femur to the ball at the tip. Because that is a thinner diameter, a lot of times the break is going to happen there. In fact, if you think back to earlier in this chapter, there was a picture of that where you saw the upper head of the femur, because of the shape of it, how the head actually kind of sticks off to the side. A lot of times the break will happen there. Patients patients will display a very characteristic deformity. It'll look like obviously one leg is much shorter than the other, and they're also the swelling can make it look like their leg is sticking out to the side. They lie with the leg externally rotated, and the injury limb is usually shorter than the opposite uninjured limb. So if you look at them, you're like, yeah, that's 6 inches, 4 inches of difference in length. A lot of time that's a dislocated or a broken femur. The patients typically are unable to walk or move the leg. Give me just a second again. All right, so actually, somebody was listening to me talk, and what we're going over, he's actually going to let us look at his X-rays, so I can show you this more when we get to the boot camps. Be pretty cool. You can actually see some real world stuff and not just what you see in these pictures. All right, so back to it again. Um, the hip region is usually tender on palpation. So, and a gentle rolling of the leg will cause pain, but will not do further damage. If you have to roll it over, it will hurt. There's no way around that. But as long as you're careful, you're probably not going to really cause that much more damage. Assess the pelvis for any soft tissue injury and bandage appropriately. Assess pulses and motor sensory function. We'll do that down at the feet. Look for signs of vascular and nerve damage. So if you see the skin starting to get pale, that cool, clammy, but only in that area and not all of them, the whole body, if it's just that area, that's usually just a sign that they have lost blood flow to the leg or to the foot. But the rest of them is fine. It may not necessarily be a sign of shock because it's not the whole body, it's just that one spot. Now, all patients with hip fractures may lose significant amounts of blood. to the point where they could die. That's our, like I said, that's our biggest fear when it comes to elderly. So you had 2 hip fractures today through the OR. We repaired 1 femoral neck, 1 intratrochanteric. That's, yeah, I'm sorry. Looking at it in the lesson plan, I could not say that damn word. Um, it's funny how a lot of y'all are having stuff happen that coincides with our lectures. Promise you, I have nothing to do with that. But it's good that you got to see it. Sucks that you had to deal with it. Yeah. Yeah, do you mind explaining that one? The ORIF? You can
That's an
unmute, Donna, if you want,
open
if you
reduction,
can.
internal fixation, and to get about a 6-inch opening from the trochanteric bursa down the femur. Put an IM nail in, which is a big rod, plate and screws. The femoral neck is basically the neck right below the ball, which would make up the ball and socket. And the intratrochanteric is the 2 little bumps that are on the femoral head. Those are the trochanteric. So that's the 2 different fractures.
Yeah. All right. Moving on to the femoral shaft fractures. These are going to be your midline femur breaks. This is what we usually would use. Let's see. Wait a minute. Lucky we got a lot of the code browns in there. Yeah. Code brown. So the midline femur fractures, this is what we typically used our traction splints for, but they're pretty rare. They don't happen very often, and that's kind of the reason why they've taken it out of the curriculum. We still want you to know about them, and we'll talk about it when we go to the. I actually have one. I'm going to bring with me. It's a personal one. We don't even keep it on company inventory because they took it away, or at least they took it out of the curriculum. But I'll show you guys when we do the boot camps. So fractures of the femur can occur in any part of the shaft, from the hip all the way to the knee joint. Just following the fracture, the large muscles of the thigh spasm in an attempt to splint the unstable limb. They're going to be in a lot of pain. The muscles are going to be trembling. Um, a lot of times, this will cause a significant deformity to the limb. Fractures may be open, and fragments of bone may protrude through the skin. So don't try to push them back in if that's what you see. There is often a significant amount of blood loss, as much as half to a full liter after a fracture, which is enough to knock you unconscious. It may not kill you, but I mean, that's just assuming that that's all the blood you've lost. Um, and that's just what's held in your femur. So if you broke both femurs, now you're looking at 1 to 2 liters, and that can be life threatening. It's not unusual for hypovolemic shock to develop, and because of the severe deformity that occurs with these fractures, bone fragments may penetrate or press onto important nerves like your sciatic and vessels and produce significant damage. Remember, your femoral artery runs along the femur as well. So if you break your femur, you have a risk of puncturing the femoral artery. And if you've ever seen Black Hawk Down, you know that didn't work out for that guy. Those injuries can be fatal. You must carefully and periodically assess the distal neurovascular function in these patients. Cover any wound with a dry sterile dressing. You're going to do basic wound care. If the foot or the leg below the level of the fracture shows signs of impaired circulation, you can try to put manual traction on the leg to get some of that blood flow back and get a pulse, but it's a one and done. If you don't get it on the first attempt, splint it like you got it as best you can and get them ready for transport to the hospital. A lot of times we will splint the bad leg to the good leg. It just makes it easier. So you're tying their legs together. Injuries to the knee ligaments. The knee is very vulnerable to injury. Therefore, many different types of injuries occur in this region. Remember, most of your body weight sits on your knees. Um, they're a pivot joint. They're very good at what they do, but they only operate in one direction. You can't actually, if you sit and try to hold your leg out in front of you, and because I used to argue this, I'm like, well, I can move my foot left and right if I have my leg out in front of me, but it's not actually your knee that's doing that. It's your ankle and your tib fib working together to kind of give you that motion. And that's what allows you to change direction, yes. But your knee is a one direction joint. If you've got multi directions out of your knee, that means you have a bad knee. And usually with that comes a lot of pain. Ligament injuries range from mild sprains to complete dislocation of the joint. The patella can also dislocate. Like I said, I really wish I could remember which football player that was, because I'm going to put that into the class if I can find it on video or something. All the bony elements of the knee can fracture. With ligament injuries, um, the knee is especially susceptible as far as ligament injuries go. And this usually happens because of the twisting forces and the bending forces that get put on the knee in ways that it's not supposed to bend. So if you're examining your patient, a lot of times you're going to find swelling. That's with any injury. Occasional ecchymosis. Definitely point tenderness at the injury site. So if you poke on it, it's going to hurt. It's going to hurt even if you're not. They're going to feel a lot of pain right there. And a joint effusion. You should splint all suspected knee ligament injuries. If you have an air splint and it's a closed injury, this would be a good time to use these. You can use SAM splints if you've got some of the bigger ones. You can use, if nothing else, you can use an ACE bandage. But you want to try to get, if it's a ligament injury, even if you didn't damage any bones, you want to stop the knee from moving. So immobilize that joint as best you can. You can use you could technically take a short board like a KED. Well, just kind of thinking outside the box here. If this is all you've got, take a KED, strap their legs inside of it, secure it down, and it's almost like you're making them a mermaid, but I mean it works, right? And that's the thing that matters. You strap their legs in so that they can't bend at the knee. For knee dislocations, these are actually true emergencies that may threaten the limb. The dislocations are very, very likely to impede blood flow, and when this happens, the ligaments also get torn. The proximal end of the tibia completely displaces from its juncture, and this can make a pretty significant deformity. So if they have this, if they have a dislocation of the knee, as in the whole joint and not just the patella, um, you're really going to see this. The lower leg's going to look kind of mangled at the top. Always check the distal circulation carefully before taking another step, and everything you do, check it again. In fact, if you've got somebody, put them on the pedal pulse and have them just hold it for the entirety of your intervention and trying to take care of the knee. Have them just sit there and just hold that pulse. And the minute they lose it, they tell you, because you'll know that whatever you just did, that's what took the pulse away. If you check the pulse and they've got it, and then you go do all your intervention, and then you go back and check the pulse and it's gone, you have no idea where you lost it in everything you just did. So you have to take it all apart and do it again. It takes a lot of time. If bleeding control is in there, now we can't take bandages off, so you can run into some issues with that. So I always try to get somebody to hold a pulse and just stay on it. A firefighter, anybody that's an EMR, anybody trained in first aid, you can find the pulse, show them right where to put their fingers. Most people that have been trained at least know how much pressure to put. They may not know where to go to find that pulse, but if you can say, hey, the pulse is right here, and mark it with a pin or something of that sort and say, put your fingers here, moderate pressure, feel the pulse, great. Let me know if you lose it. And then you go back to doing your interventions. The direction of the dislocation refers to the position of the tibia with respect to the femur. So a posterior knee dislocation is the most common. This occurs in almost half of all cases. Commonly, the anterior and posterior cruciate ligaments, your ACL and your MCL, these get damaged, but there's also a high risk of injury to the popliteal artery, and that's where this becomes a real life threat, be it for blood loss. It's even if it's not a life threat, it's definitely a true emergency because they could lose their foot, they could lose their lower leg. Medial dislocations result from a direct blow to the lateral part of the leg. So if you get hit on the outside, like it is football season. If a football player goes to tackle somebody at the knee, and they're coming in from the side, they hit them on the outside, and their knee caves in toward the other leg, that would be a medial dislocation. Patients will typically complain of pain in the knee and report that the knee gave out. So if you've ever heard they say their knee gave out, that's what happened. It kicked the wrong way. A posterior one that I've seen in a video, actually, it wasn't a live call, but it's a good example, and you can find this on YouTube or Jim Fail or any of those if you ever follow it. There was a guy that was doing these leg presses. It's in a gym if you've ever been in one where you sit down at ground level and your feet kind of go up to a platform, and you can put 600, 800, 1,000 pounds worth of weight on these things. They've got the bars to hold it, and you unhook it, it lowers down, and you just push it back up the track. Um, if you do a heavy weight like that, they always tell you not to lock your knees out. And the person in this video didn't follow that advice. He was lifting pretty close to 1,000 pounds. I forget what the actual weight was, but he got like 3 or 4 reps in, and then he tried to take that break. And when he did that, he locked his knees out, thinking that he would just let his bones hold the weight. But that amount of weight was more than what his knee joint could handle, and it kicked his legs in backwards. And the guys that were standing around next to him actually had to try to catch the weight and stop it from coming down and breaking everything else between the platform and him, basically. Um, that was just one of those cringe videos. And I was like, oh God. He they could fix him pretty easily, hopefully, but hopefully he didn't get any major damage to his arteries and that kind of thing. Anyway, if adequate distal pulses are present, you can splint it like it is, and transport patient immediately. If you don't have a pulse, get one attempt to kind of put traction on it, see if you can't get one, and then splint it like it is and go. Fractures about the knee. Fractures about the knee may occur at the distal end of the femur, at the proximal end of the tibia, or in the patella, anywhere in that entire section. It is easy to confuse a non-displaced or a minimally displaced fracture about the knee with a ligament injury. So management of the two types are as follows. If there is an adequate distal pulse and no significant deformity, then splint the limb like you find it and go ahead and get them to the hospital. If there is an adequate pulse and significant deformity, splint the joint. I'm sorry, let me back this up. If there's an adequate distal pulse and no deformity, splint the knee straight. All right, so straight leg, use an air splint, that kind of thing. If there's a pulse with a deformity, splint it like you see it. All right, so in other words, don't try to fix the deformity. If you've got a pulse, just leave it alone. And then if there is no pulse, try to provide some traction. See if you can get a pulse. If you can, fantastic, then splint it. If not, splint it like you found it, mark it, and then drive faster, because you don't want them to lose their leg. You don't want a chance necrosis setting in and getting loose in the body, that kind of thing. Dislocation for the patella. This is just your kneecap. A dislocated patella most commonly occurs in teenagers and young adults who are engaged in athletic activities like football, soccer, most of your sports that have you running around. Usually the patella dislocates to the lateral side, so it kicks out away from the side of the knee toward your outer, like your actual left or right side. The displacement produces a significant deformity in which the knee is held in a moderately flexed position and the patella is displaced to the lateral side of the knee. Anybody in here ever experienced this? I've been fortunate. I haven't had any of these injuries. I've had ankle sprains, and that's about it. No? Okay, yeah. Yeah, I don't wish this on anybody. These just sound gruesome. Splint the knee in the position you found it. Most often, this is with the knee flexed to a moderate degree, so they're going to have a bend in their knee. That's okay. Depending on um, depending on the bend of the knee and how you splint it, you may have to put your patient on their side to get him into the ambulance properly, get him comfortable, that kind of thing. Just depends. Apply a padded board. Use some splints to the medial and lateral aspects of the joint, so left and right side, extending from the hip to the ankle, so all the way down. Injuries to the tib and the fib. Remember, your fib is your small one. I always say feeble because it means that it's not load bearing. Your tibia is the actual load-bearing shin portion of your lower joint. Whenever these break, they often break at the same time. Even a single fracture may result in a severe deformity, so significant angulation or rotation may be seen. And open fractures of the tibia are relatively common. These fractures should be stabilized with a padded, rigid, long leg splint or an air splint. But if it's an open injury, then be careful with those air splints because you could pop them, and then you just have plastic around the leg. You don't actually have any real stability anymore. For your ankle injuries, these are very common at the joint because all of your weight is sitting on that joint, right? I mean, our ankles are surprisingly for their size, they're very, very stable. But when you start trying to do lateral movements or you just land on them, you can cause some damage here. Ankle injuries occur in people of all ages and range in severity from a simple sprain all the way up to a severe fracture dislocation. Any ankle injury that produces pain, swelling, localized tenderness, or the inability to bear weight should be seen by a doc. We don't have MRIs, we don't have X-rays, we really don't know what the damage is. We don't know if it's muscle, ligament, bone, nerve, any of that stuff. The most frequent mechanism of ankle injury is twisting, which stretches or tears the supporting ligaments. So, like I said, athletic people, a lot of times you'll see it when they run in one direction and they try to shift their weight and move, like change their direction. Or a lot of times they'll either hurt their knee or their ankle. Book of mine up a couple years ago. Back still hurts from time to time. I didn't have insurance, so I just let it heal. Well, man, I mean, I can't say anything different. I was in a motorcycle accident a while back and jacked up my knee. Same thing. I was like, you know what? It's going to cost me more to get it fixed, even with insurance, just to let it heal on its own. Um, yeah, I mean, I probably shouldn't have because it messes with my ability to run when I'm doing my PT tests. But I mean, at least I can still do that. So that's something. You can manage the wide spectrum of injuries to the ankle in the same way. So you address any open wounds, stop any bleeding, stabilize the joint. You can even just an ACE bandage. That's what usually people use. Use some ice to fight the swelling and get them to the doctor. They put you in a boot. Oh, you're in a boot. Oh, geez. What do you do? You got to have a cool story. Anytime you break a bone, you got to have a cool story. Bar fight, saving a bunch of kids from a burning building. You got to have something. we'll go with that one. All right. Foot injuries. So injuries to the foot can result in the dislocation or fracture of one or more of the tarsals, metatarsals, phalanges, or the toes. Um, what you see in this picture, kids are bad about doing this. They think that if they land on their feet, they're not going to damage themselves. But a lot of times they do, and this is called the Don Juan syndrome. They first of all they hurt their ankles and their feet because that's a direct impact with the ground. But all that energy's got to go somewhere, and it typically travels up their bones and then starts to mess with their hips, their lower spine. They cause damage up there as well. So if you're going to respond to a kid or anybody for that matter, but definitely a child, they have a habit of this. They land on their heels. They tell you that they hurt their feet. Pay attention because they probably are going to have some injuries to their hips. Um, any of that area up there could be causing some problems. If you suspect the foot is dislocated, immediately assess for pulses and motor sensory function. Think about the foot. The way we check for a pulse is right where the foot meets the front of the like the anterior portion of the ankle. So if they've hurt their foot, say like in the metatarsal range, we have no way of knowing if they've got a pulse to their foot other than we look at it and we say, all right, your skin is warm and pink and you can wiggle your toes. That's the best we can do. The nearest pulse point is proximal to it, so it's not gonna tell you anything. To splint the foot, apply a rigid padded board. You can use an air splint or a pillow splint. Leave the toes exposed. That way you can tell whether or not you've lost your pulse. If their toes start to get cold and clammy, you've lost your toes. But if you cover them, you're not going to know that. All right, strains and sprains. We talked about this a little bit earlier. So treat everything as if it's a fracture because we don't really know. General treatment is similar to the fractures and includes the RICEs. This is an acronym for you to remember. Rest, in other words, get off of it. Put some ice on it to fight the inflation or the inflammation rather. Compression, elevation, and splinting. All of that is to try to keep the swelling from getting too bad. Amputations. We're almost done, guys. I know it's past time for a break, but we probably only have like 2 or 3 slides left, so we'll just soldier through this and call it a night. For amputations, control bleeding and treat for shock. That's going to be your biggest concern. It's not like you're going to replace the bone unless the hospital may be able to, if you can find it and bring it with them. But in EMS, there's no stabilization. The body part's just missing. So treat for what's in front of you. There's probably going to be a lot of bleeding, and with that comes the potential for shock. Surgeons today can sometimes reattach amputated parts. There's a lot of stuff that depends on that, though. How long ago did they amputate it? What was it that got amputated? How badly was it severed? Was it a clean break or a clean cut rather? That kind of thing. With a partial amputation, make sure to immobilize the part with a bulky compressive dressing. God, I can't talk. And splint to prevent further injury. Don't sever any partial amputations. Don't finish them off. It doesn't make it better. It makes it worse. Control any bleeding from the stump. And if the bleeding is severe, quickly apply a tourniquet. With the complete amputation, make sure to wrap the clean part in a sterile dressing and place it in a plastic bag. Then take that plastic bag and put it in another bag with ice. Just like if it was your fingertip or something. If anybody's ever taken a first aid video, they show that happening. That way the amputated part stays cold while you get it to the hospital. All right, so for compartment syndrome, and this is going to be it for the night. We've talked about this before, but it shows you the importance of this and the fact that it's showing up again. All right. We talked about it when we talked about burns. If you guys remember, that is where, like, when the skin gets burned and it can't expand, it doesn't have that elasticity anymore, and the swelling starts. The swelling can't swell out, the skin won't allow it. So the swelling starts to swell inward, and it puts pressure on your nerves, puts pressure on your veins, that kind of thing. And you lose the ability to pass blood and nutrients back and forth, and you also lose the ability to get impulse down the nerve because they're cramped down. So we're going to kind of look at this from a traumatic standpoint, but it's pretty much the same thing. Compartment syndrome most often occurs with a fractured tibia or a forearm of children, often overlooked because this doesn't happen very fast. In fact, usually your patient's going to be at the hospital before they really get compartment syndrome. But we're going to talk about it. Compartment syndrome typically develops within 6 to 12 hours after the injury, which is long after we've gotten them to the hospital. Usually the result of excessive bleeding, a severely crushed extremity, rapid return of blood to the ischemic limb, and this syndrome is characterized by pain that is out of proportion to the injury. In other words, they have an injury at the elbow, but their entire forearm starts to hurt. The pain is much bigger, covers a much bigger area than the injury, and it usually is past the point of the injury. Pain on passive stretching of muscles within the compartment. Some pallor will be there. Decreased sensation because, again, you're like your hand is going to sleep, your foot's going to sleep, whatever. And decreased power. They won't be able to squeeze. They won't be able to move their foot as hard against your hand as normal. And then the worse it gets, the worse that will get, to the point where they can't feel it anymore. They can't maneuver their fingers and toes. And if it doesn't get fixed, they wind up losing the limb. If you have a pediatric patient with a fracture below the elbow or the knee, be on the lookout for these signs and symptoms. Extreme pain is pretty common, which is kind of hard to find because they're usually screaming because of the actual injury. Decreased pain sensation as this progresses. They're going to start to lose pain sensation because their nerves are starting to go dead on them. pain on stretching of affected muscles, and decreased power, just like we were talking about before. These are indications that the pressure with a fascial compartment is elevated. And as EMTs, unfortunately, there's not a lot you can do. We do what's called a fasciotomy, where they'll take a scalpel and they'll cut the skin to allow it to open up more and let relieve that pressure. But there's not something we can do. So if let's say it's an older injury, somebody ignored it and they waited 5 hours to call 911 when all this was starting to take effect. If you show up and you do see the signs of this, first of all, shame on them for waiting, but um, get a paramedic out if possible. Either get a paramedic or a helicopter, um, or if you're close enough to a hospital, you can just go ahead and get them to the hospital. But whatever's faster, get that, because the fasciotomy can relieve it. That's something that can be relieved in the field. It's just not something we can do as EMTs. So know your additional resources, recognize that in the field, and see how fast you can get them some help. Reassess neurovascular status frequently during transport if you are actually the one transporting these. Same thing. I wouldn't wait 5 minutes to recheck their pulse on these, even if they're a stable patient. That one spot, I would be as close to a constant pulse check as possible, because I want to know as soon as I lose that pulse. That way I know roundabout how long they will have gone without it by the time I get them to the hospital. And that's going to be it, guys. This concludes your trauma module. Um, what I will do, because tonight's Tuesday night, I'm going to extend your deadline on the trauma module test until past the weekend. So I know your schedule says it is due by Thursday. I'm going to give you until our next Tuesday class to do that module. Doesn't mean we're going to wait. We're still going to move into the last module on Thursday. But this way you have some time to study. You can go back, look at what we've already covered, get through tonight's test and all that stuff. And then you've got the weekend to work on closing out the module. But I need it done by Tuesday. All right. So Thursday, we're going to start working on PEDS. That's a very large, very hard chapter. Um, so just, keep that in mind. It's not a break. I'm not giving you guys a break. I'm just giving you more time to get this out of the way. All right. So your pin for the night is going to be BC Bravo Charlie 31 O. BC 31 O is an Oscar. Any questions? Any questions on trauma as a whole? Any questions on the class and where things go from here? Because like I said, we got three lectures left and you're done listening to me drone on. Uniform and dress code at boot camp is just dress functionally. I'm not going to make you wear your polo shirts or anything like that. But if you guys have not ordered your polos by now, now's the time to do it, because you're going to need those for the ambulance ride-alongs. As far as, I'll give the pin in just a second. All right, so you have to have a student uniform for your ride-alongs. For the boot camp, I really don't care what you wear; it just needs to be functional. So closed-toe shoes. Um, make sure you're decent. I shouldn't have to say that one, but make sure you can, bend over your patient without winding up on Pornhub, that kind of thing. Um, the pin is Bravo Charlie 310, as in Oscar. As far as getting the shirts, if you go to our website, there's a shop option at the top. Um, for your boot camp, you can wear your department uniform, yes. For your ambulance ride-alongs, no. The ambulance doesn't allow it. That's not even our rule. That's the ambulance. You have to be identified as a student. So um, your department, Winston, y'all already paid for your shirts. And that's it. Now the rest of your uniform is good. You wear your uniform BDUs, your boots, your belt, all that stuff is great. You only have to change your shirt. I'll tell you what I'll do. I will send I'll put the link in the Facebook group. It'll just be a direct link. Do I need to get with? No. No, because I don't. John may not remember, but I'll make sure you guys have your shirts when we do your boot camp because your department covered yours, so y'all don't have to get your own. But for those of you that are putting yourselves through the class, um, you can order your shirt from our website. And I prefer y'all to do it because I don't have to keep up with your sizes or anything like that. But it just needs to be a black polo, and it will automatically come with our logo already on it. All right, ladies and gents, enjoy your Tuesday night. And we will, let's see, after next week, we'll have class. You won't have class. Nope. This next coming week is your last week of lectures, and then there will be a little bit of a break between this and your boot camp to get you through the holidays and just give you a break. You haven't had a break since you started the class. I haven't had a break since I started the class. So, um, but I'm always around. If you guys have an issue with something, if something doesn't make sense, let me know. Y'all's boot camp, I believe I'm going to be there for the 11th through the 15th of January at Pascagoula. It'll be the 11th through the 15th for Pascagoula. It'll be the 18th through the 22nd, I think is a Monday through Friday for Alexandria, Louisiana. And the Abita Springs location will be the 11th through the 15th as well. That'll happen at the same time as Pascagoula. I will be at your boot camp, but I may not be there all day every day because I'm going to be focusing on Pascagoula's. It'll be Pascagoula's first one, whereas Abita's already had one, so they kind of know what they're doing. But yeah, you're going to see me. I'll be there. I just won't be running it. I'll have Trevor Sansom running y'all's. I mean, come on then. Y'all have the ability to choose wherever you want to go. And class is done, guys.